Hey, welcome. Last time I spoke in front of you, I was talking trash the whole time. So I promise not to talk trash. So we you and I know that joke. Yeah.
I really thought a good video on incineration and how that some of the other
We'll
countries are
definitely
really.
talk. Yeah, definitely.
We're gonna switch gears here.
But let's talk about something different today.
Yes.
So, for the record, my name is David Rochefort. I'm the prime sponsor of HB 1222. I'm from Littleton, and I represent Grafton One, which is Littleton, Lisbon, Lyman, Bath, Monroe, Sugar Hill. So, as you can tell from the towns I represent, this is I come from a very rural area. Access to healthcare is a challenge, and I'll get into that in a little bit as I go along my comments. One thing though I do want to point out is the title of the bill. The title of the bill is relative to physician assistant scope of practice. Now, that's erroneous. That title is erroneous, really. This does not change scope of practice for physician's assistants. This bill will not allow physician's assistants to do more than what they're doing now. So probably what this should have been titled is an administrative change in the way physician's assistants work in New Hampshire. Before I get into too much, I do want to explain there is some mention about the VA and in the bill pertaining to PAs working in the VA. That has not received any objections, and it's here to make sure that the PAs at the VA in Manchester are not inadvertently restricted by state law. This language that I put in, this bill that I put in, the genesis of this was actually a constituent call. And I have no intention on jumping into the world of physician's assistants. When I started filing bills last year, at the 11th hour, I got a call from one of my constituents who's been a physician's assistant for 20 plus years in Littleton, in the North Country. And they called to tell me that, hey, the physician that I work with that's part of this practice is now retiring. And according to the law, despite the fact that I've been a physician's assistant and seen patients independently for 20 years, I have to go and find another physician to collaborate with. And this is really something that needs to be changed. It was something that was binding her to into a certain situation because of this this change. So, I did some research on it, and I said, listen, it's kind of late. We're kind of at the last minute. Started doing the research on it, and I realized that as I dug into this a little bit, she was right. I mean, physician's assistants are, they're trained, they're qualified, they see patients. I'm going to tell you a little personal story in a minute. But throughout the entire point of their entire career, they have to have what's called a collaborative agreement, which is a piece of paper, really. It doesn't require any direct supervision of PAs by MDs. In fact, we heard stories where there were out-of-state MDs signing these collaborative practice agreements for the small fee of $1,000 a month. It was just a technicality, really, in what my interpretation of it, and it really, because it lasts and that the requirement is for the entirety of their career. I mean, one could say that's indentured servitude, and because it's holding them captive throughout their career, regardless of the experience level. So one of the things I assumed is that this was also going to be, this also had to be done for nurse practitioners, because nurse practitioners are similarly educated and equally capable and qualified as PAs to provide high quality care. But I learned that the nurse practitioners have no such regulatory requirements placed on them at any point of their careers, whether they're new grads or 20-year graduates. And we know, all of us know, I mean, I've seen it, I've experienced it, my family's experienced it. The nurse practitioners have been providing high quality, cost effective care in New Hampshire without any concerns to patient safety. So one of the things that after I introduced the legislation, I learned from the New Hampshire Physicians Assistants Association that the PAs were, there were cases where PAs were losing their jobs or unable to get hired, losing out on career advancement. And we have a PA today that I think is going to address that with her personal experience with that. This is again, this because of this administrative burden. I'm glad I got more than 3 minutes, but I won't go much longer. So this really, for me, this has become personal because I live north of the Notch. I'm from north of the Notch. Our access to care up there has really become a revolving door of patients. My wife, for instance, within 18 months, had 3 providers, PAs, NPs, MDs. They stay, they leave. By removing this need for collaboration, we're now making, and there are other states that are exploring this as well. We're now making New Hampshire a good place to practice, and where PAs have more opportunities, they have more access to career advancement in jobs, and that translates into access for patients. We have 2 schools in New Hampshire that are producing PAs. Every year they're graduating PAs. If we can make this an environment that they want to be in, I mean, that just helps everybody, improves access. 3 weeks ago, my wife had surgery back in March, and 3 weeks ago she was having trouble as a result of the surgery. And she has a heart condition, and we're sitting at the table for dinner, and she nearly passes out. So her head hits the floor. She's falling out of the seat. I wasn't going to take the chance of, hey, let's see how this goes. I said, let's go to the emergency room. We have an excellent facility right in Littleton Regional Hospital. Phenomenal. We go in there. They got us seen. They worked her up for a heart issue. They worked her up for a stroke. They worked her up for a number of other things. And fortunately, she was fine. And it was a adjustment in medicine that she had, and end of story. But the care that she got was done by a physician's assistant. Every single minute, every single action, every single monitoring was done by a physician's assistant. We never saw an MD in that whole time. So the fact that these folks are providing care, they're meeting needs. This will just allow them to do that a little bit further. I had a number of notes here I want to hit on, but I think I've hit on a lot of them. One of the things that I want to point out too is, again, and I talked about this initially, this bill will not expand the scope of practice of physicians in any way. It does not. If you look at the scope of practice, which is 318D, physician's assistants, 318D 3B talks about physician's assistants scope of practice. If you look at the bill, the areas that affect, for instance, what they may provide for services, what they may provide, what the kind of education, training, experience they have, Roman numeral 8, what they can do, prescribe, dispense, order. This isn't changing that. This bill's not changing that. We had no intention on, allowing them to do more, but just operate without having the constraints of this administrative paperwork. So again, there are other people going to talk about the history, perhaps, of where we've gotten, but I do want to understand that this collaboration, these collaborative agreements that are currently in law, there's no requirement or obligation for direct supervision. The MDs signing them have to be available on a phone call. The MDs are indemnified, and again, I told you about the cases where doctors were charging $1,000 a month to enter into these things. So we talked about that. The other thing is, so I want to tell you, and I know that I've spoken to probably both of you about this and various things. I'm on the Board of Pharmacy. I'm the president of the New Hampshire Board of Pharmacy. I have been on the Board of Pharmacy for 8 years. I want to point out what the boards do over at OPLC. And the boards are the boards of pharmacy, the boards of medicine, the boards of nursing. They are there. We don't charge memberships. We don't have lobbyists. We don't, we aren't a political organization. What our sole mission is to protect public safety. So, I know in the Board of Pharmacy, my experience is that if we have bills that are coming out of the legislature that we feel are a threat to public safety, put the public in jeopardy, we comment on that and we oppose those bills. The Board of Medicine has the same opportunity as well. And I think it's important to note that they're neutral on this bill. Now, again, the Board of Pharmacy, we don't support a lot of stuff, but just because that's not the nature and that's not our role. But we, in our role, if there was something bad, we would oppose it. And again, the not only does the Board of Medicine stay neutral on this, but in a statement that I received from their board counsel, the board recognizes the challenges faced by physicians' assistants in New Hampshire relative to collaboration agreements restricting employment opportunities. The board, as a general matter, supports changes in statute for physicians' assistants, which would ensure appropriate education, collaboration with medical teams, and limits on scopes of practice based on training, experience, and team support. HB 1222 does all of that. There's no change in the education requirements. The physician's assistants are getting graduate degrees, with real-time experience with that. We added that if you look at what we did in the House, we amended the original version, so new grads have to have 8,000 hours of collaboration with a physician. So we're recognizing the fact that there is some value to that, but at the end of the 8,000 hours, they can practice on their own. Now, the exception to that is if these PAs are working in a health system amongst MDs, that requirement is not there, and that was understanding that they are. Around folks all the time, and they still have to collaborate. That's the other thing with this, is there still is an obligation for PAs to collaborate. It's just not in the piece of paper. Again, there are other folks that are going to come behind me to speak some more about the specifics. I've hit the points that I want to talk about, but if there's any questions, I'd be happy to take those.
Questions from the committee? Senator?
So thank you, Senator Abard, and good morning, Representative. Thank you for taking my question. So just for, if you didn't already know this, and for anyone in the room, I lived in the North Country, ran an ambulance service in Woodsville for a number of years. I'm very familiar. And in fact, when I got married in West Bath. So yeah. I am very familiar with the North Country and work to actually shore up the primary care safety net through emergency medical services. So I am pro systems of care. So I'm going to limit my questioning right now. I want to get that out there, but something that you said, and so help me out here. I understand this isn't a change in the scope of practice. All along, I've understood that this is about the nature of the collaborative agreement. And you had said that some work or some work now without any direct supervision. Now, I know 2 years ago, I believe I don't know if it was you were before us or there was another member of, I believe it was a Senate bill, that we changed the arrangement from being an in-person arrangement for collaborative agreements to being off-site and allowing for the phone call to then.
The doorway. Just keep it. Yeah, sorry.
No, somebody has to be the fire marshal today. It's going to be you. So the nature of the collaborative agreements had taken a change, so it was there could be this off-site conversation. So we'd taken that step. But I just want to go back to direct supervision. I worked in an emergency department in the central part of the state where it was MDs and PAs. And the PAs, they were not directly, say, supervised when they were in the room. They did an incredible job, no doubt. But they still had to go and report out on the cases as part of that agreement with the attending physician. So that's my understanding. Is that correct, that direct supervision is still in place with the exception of the phone, which is an in-person direct, but it still creates this immediate line of communication?
Yeah, so here's what the law says. It says a statement, this is the current law right now, A statement that although collaboration occurs between physician assistant and physicians and other healthcare professionals, a physician shall be accessible for consultation in person by telephone or electronic means at all times when a physician assistant is practicing. And you bring up a good point in that, physicians assistants who are working in a health system, that part of their job description and the policies of the facility may be that they're constantly checking. Maybe there is a direct supervision. This isn't changing that. The employer can still do that. And we wanted to make sure that the employers had that flexibility and ability to do that because, we know that PAs are used in a variety of circumstances. I mean, everything from an ER provider to an ENT to whatever. And depending on the scope and depending on what they're doing, the facility may have different requirements for each person. But no, for direct supervision, that's the law says a physician shall be accessible for consultation in person, by telephone, or electronic means at all times when a physician's assistant is practicing.
So thank you. Follow up. So perfect. You helped clarify. I mean, it is not always in person. It was in person for conversation, but not at the bedside necessarily. And then we changed it 2 years ago to be the phone consultation, which is a line of supervision. I just wanted to establish that. But you know what I didn't know, Representative, is that people were being charged for collaborative agreements. And so can you explain the nature of that? 'Cause I'll say the out-of-state physician phone piece was, that was all part of this movement 2 years ago to, again, create not just more opportunities, but allow there was a need for people, healthcare providers in the workforce, including physician's assistants, having always a physician on site, say at an urgent care, wasn't working out. It wasn't allowing for the types of hours necessary that you speak to, especially in the North Country. So this change was made. So I'm not as worried if it's a licensed physician, if there's an established relationship, but the charging for that, who allows that?
Those are reports that we were getting from PAs that were being contacted or engaging in relationships with out-of-state physicians to enter into this collaboration agreement for a fee. That's what was reported to us this was even after I decided to take this, and I don't think there's anything prohibiting that, but it's, if you've got somebody that needs an agreement by law in order to practice their lifestyle to provide for their family, I mean, it creates a scenario that it's tenuous and it's questionably legal. In my opinion, it's not ethical, but that's my thought on that.
Okay, thank you so much. I
Yes.
certainly, I may have more questions, but understood.
I'll
Good.
be here.
Okay.
All right.
Seeing how nobody else in the committee wants to ask questions. Thank you
Thank
very
you.
much. So I do have a few representatives here that I'd like to put at the front of the line, but traditionally we do that. But if I could beg for your patience, I'm going to ask Senator Sherman to come up. Yeah. So there is a time limit of 3 minutes. So you didn't hear that. So. Is this your first time here?
Yeah.
I remember how. Thanks.
Welcome back.
Thank you very much. I was going to start out by thanking Senator Bradley, but he's not here. So, Mr. Chair and esteemed members of the committee, or member of the committee, it's great to be back. I am here to testify in opposition to this bill. I have worked as a physician for 30 years, as has my wife, and none of that time has been without having PAs working alongside both of us. But, oh, there he is. But I've also worked here as a state rep and a state senator on behalf of the physician assistants. I've prime sponsored at least 5 bills, expanding their scope of practice, rewriting their licensing statute. Worked in 2022 with many of you as a co-sponsor of a bill sponsored by Senator Bradley to rewrite the agreement between physicians and PAs. But we've worked really to address many of their concerns in the North Country, whether it's allowing them to work on advanced directives in psychiatry or in or being able to pronounce patients dead. And all of this was in response to the actual way they practice in the North Country and in rural settings. But I am not a proponent of independent practice. And the reason is fairly straightforward. A physician in independent practice has at a minimum 4 years of medical school and a 3-year residency and internship. That's the minimum. The requirement that I went through was an additional 3 years on top of that. That adds up to 17 years of post-high school training before I was in independent practice. 17 years. The average time that means in actual mentored clinical experience for a physician is at least 25,000 hours. We're talking about letting people go into independent practice, whether if it's in a setting where there are other physicians around, with 0 hours. We're talking about 8,000 hours of any kind of clinical exposure. That's what this bill has. It's one or the other. You can come straight out of being a PA as long as you have physicians around you and you're in that setting. Or there's 8,000 hour requirement. But it's not a mentored, structured clinical training. I'd like to give 2 brief examples. Is that the end of my 3 minutes? Ouch.
I'll give you another 30 seconds.
Okay, 2 examples. When I was practicing in rural Virginia, a patient came into the emergency room with unexplained chest pain, and over the phone, listening to the ER doc, I was able to diagnose a syndrome called Boerhaave's. I'd never seen it in my clinical practice, but I'd encountered it in my training, both in my education and also in my residency and fellowship. That is a life-threatening emergency. The patient did well when they went off and were seen by a thoracic surgeon. A second is even more straightforward. Patient came in with chest pain, abdominal pain, bloating, and an inability to swallow. What was missed on the chest x-ray was what's called a double bubble sign. That's a gastric volvulus. If you've ever owned a large dog, it's known as gas bloat in animals. Surgical emergency. If it's missed, the patient dies. But I had never seen it in my clinical practice of medicine until that day, but I knew about it. And that is what the difference is. That level of training. I've had PAs with me my whole career. It's been a wonderful relationship. I've advocated for them here, but this is one step too far. So in the interest of patient safety, I would ask you to ITL this bill. And one Bradley special, if there is one, would be to create a mechanism for reporting all these anecdotal issues that have been coming up with the work we did in 2022, so that we could actually get some data and know how to fix the problems. Thank you very much, and I'm happy to take any questions.
Questions? Seeing none, thank you very much. Appreciate you coming here.
And thank you, Senator Brad.
Are any of the representatives in a hurry? You're in a hurry.
Thank you. For the record, my name's Tony Lekis, represent Hillsborough 38, the towns of Hudson and Litchfield, and I think I'll comfortably meet your 3-minute limit. My involvement with this bill is that it came before my committee, House CDNA, and I chaired the subcommittee dealing with it, and we spent quite a bit of time working on it. I'm not going to repeat what was said before. What was said about issues on access in the North Country, certainly true from what we heard, but it's not limited to that. I'm in Hudson, and we've dealt with Southern New Hampshire Family Practice, and the other representative, Lekis, my wife, her primary care physician is actually an ARNP. But when I was looking to see who was there, I was very surprised to see no PAs, although they have plenty of NPs. And so I never knew why that was until the testimony we heard during the subcommittee meeting, and that apparently they had PAs, but they had problems getting these collaboration agreements, and they actually had to get rid of them and replace them with NP. So, the problem with PAs is not just in rural areas. I want to make that point. I've also heard some comments that the work the committee, the work on this bill was rushed, or was pushed through or something like that. I can tell you from my personal experience that's definitely not true. We heard from a lot of people, did a lot of work on it. The only thing that happened late in the game is that there were some concerns expressed last minute about PAs coming out of school and setting up their own practice. The bill originally did not have the 8,000 hour requirement for independent practice. And so there was a last minute compromise to add that. How likely it is that PA straight out of school is going to set up their own independent practice, I'm a little skeptical about that. I wonder about them getting insurance in that case. But in any case, part of that arrangement was they are required to have a collaboration agreement for the first 8,000 hours if they're an independent practice. If they're in a practice with other physicians, with physicians who are working in similar areas that the PA will be, they don't need the formal collaboration agreement. However, the bill makes it was true anyway, but the bill makes it explicit that they have to collaborate and follow whatever rules their employer has on collaboration. I mean, some of that was mentioned before. So they're going to be in an environment there where collaboration is generally the norm, and it would be their employer that would be making sure that occurred. And I think that's basically it, unless there are questions.
You did very well. Thank you, Representative. Questions? Seeing none. Thank you very much.
Thank you.
Appreciate your time. David? I'll have you next.
Thank you, Mr. Chairman. Thank you, honorable members of the committee. I find myself in an incredibly uncomfortable place because I'm surrounded by friends, some of whom I've worked with for a long time, who I have to disagree with on this issue. Only one enemy in here, but I'm just joking. But anyways, everybody's a friend. As you know, I'm a physician. I'm also a practice owner. I've been in medicine now for nearly 40 years. I have worked with easily over 100 physician's assistants in my career. I've had the honor of actually marrying 2 nurse practitioners because my wife is a identical twin and they're both NPs. So I've been able to see this world from a lot of different perspectives. My opposition to this bill is actually qualified. I'm actually thankful to the sponsor for bringing this up because I think it's an important issue and I think it needs to be studied. However, this bill is not the way to do it. When I was a kid, I built my first table when I was 5 years old. And the one lesson you learn very early when you don't have a lot of supplies is you learn that you need to measure 3 times and cut once. Cutting corners is never a good thing. And my concern about this bill is that's exactly what was done here. There was a good reason why the bill was brought up. There were 2 physician's assistants that were facing loss of practice because of a specific situation, which was unfortunate. They then created a bill. My concern is this: they never reached out to anybody to talk about it. They didn't reach out to other physicians, the medical society. They didn't talk to me. They didn't talk to the hospital association. They didn't talk to virtually anybody in creating this bill. I was actually told on this House side that my opinion didn't matter. And this really bothered me a lot, because not only am I a physician who owns a practice, who employs physician's assistants, but I also have been a longtime member of the legislative committee of the Medical Society. I was told that my position was inherently biased and it didn't matter. And I was actually even told to not speak on the House floor because of that. I've worked with PAs for a long time. I really know what they can do, and I really appreciate what they can do. But I also know what their limits are. And as Senator Sherman had said earlier, you know, when they graduate, they have the equivalent of less than a third-year med student's level of education. There is no place in the country that will allow a third-year medical student to be licensed and practice independently. When they come out, they really don't have a skill set. And our job as physicians is to hire them, teach them what they need to do, and then allow them to become what they need to become, which is wonderful. I really enjoy doing that. The problem is that unlike me that paid for that, or a nurse practitioner that paid for that, when we hire a new nurse PA, it's $95,000 plus benefits, and it takes 12 months to get them up to speed. I think that we need to focus. What I would ask you to do is this, in my 30 seconds? 22?
That's a gift.
All right.
So
In my remaining time, we offered an olive branch. I think this issue is worthy of study. The amendment that we offered was to create a study group, a multi-stakeholder study group, to look at this, study it in detail, and make reasonable recommendations on where to go. But I'm thankful for that they brought this issue up, but this is just not the way to do it.
thank you for your testimony. Questions from the committee?
sorry.
Seeing none. Oh, Senator Bradley.
So not so much a question, but you brought up, collaboration, consensus, sitting down and talking. I'm told that after I met with both sides independently, that one side has just unilaterally said no discussions. We're not willing to talk about anything. So it puts us in a bind.
I get it.
And if you play winner take all, there's a winner and a loser.
Yep.
And so for everybody in this room, that is, unless there's an agreement to, work over the next week when we exec this bill, a week from today, there'll be a winner and there'll be a loser, and that is unfortunate.
Oh, can I comment?
I'm sorry to stand on my soapbox, but you brought up.
No, it's fine. I brought that handout on collaborative agreements for a reason. They're important. And this is actually created by an attorney who represents PAs, and they wanted to tell them why it's important and why it needs to get done. I totally agree with you. This is an issue that really needs to be sat down and talked with. This is not a simple issue, and I'm sad that you're saying that it's a winner take all, because it really shouldn't be. I think in the end, I spent all day yesterday talking to PAs about this bill because I wanted their point of view too. And virtually every one of them said 10 years before they were ready for independent. But they also brought up a lot of individual circumstances where independence was important. And that's why I think that independence is important within certain parameters. This bill's not it.
Thank you very much for your testimony. Representative Calabro. How do I say your last name? Calabro. Thank you.
I have to go.
Regina doesn't want me to act. Yeah, she doesn't want me to take the
We're
one.
not. You've got.
Yeah.
Oh,
We're good.
I have to.
Do what you gotta do.
Thank you, Senators. I am Representative Karen Calabro, PA. I graduated from MCPHS University in 2015 as a much older student. I did think about getting into medical school, but unfortunately at my age, the only school that was available to me was UMaine, and I have a child with special needs and autism. I wanted to practice because I was an EMT volunteer in Milford. I absolutely love doing that, but I am not good at emergency medicine. You have to think on the spot very quickly, and I saw myself more as seeing the care of a person from beginning to end. I would then go on to study. I would end up graduating as UMass Lowell's valedictorian in continuing ed. I only made a 3.98 because I met my husband. I'm at an A- in
It's always the
English.
guy's fault.
Yeah, he's distracting. I would obviously go on to be accepted to MCPHS University, and that is where I got a world-class education. I need to reiterate that the scope of practice is not known to MDs because they don't go to our school. But I know it, and every PA behind me knows it, and we study it for the blueprint, and we're tested on it, and we have ethics classes that are made abundantly clear. I watch students flunk out of ethics. I want you to know that the scrutiny of having integrity people out there practicing medicine is key. And I was one of those people. Now, I would go on to become the mobile crisis medical director of Harbor Care. I chose to do that line of work after starting in urology, which is very lucrative. But I wanted to do primary care because a certain somebody called our state a cesspool of addiction. And I would go on to get a Data 2000 waiver and be able to dispense buprenorphine. I was a MAP provider. I was one of the best they had. And they made me quality assurance medical lead after a year and a half. That's what happens when somebody cares about something. It should not matter what the letters are after your name. At a certain point, you've learned what you need to learn. But my scope of practice is limited. I know what that is. It galls me and insults me to think that somebody would say that somebody is going to go rogue out there and open a practice just to make money. There are so many stopgaps in place that would prevent that. Business liability insurance for one, insurance repayment for another. The thought and the loss of your license being the most important. It's already in the RSA. Now, I spoke specifically on the amendment that was one that passed the House on a voice vote. And I was the one who was on the phone working on that amendment. And I asked specifically, and I hope that President Bradley would hear this part, what were the sticking points? What were they? And that's what we put in it. And that's why it passed on a voice vote. I wasn't going to let this go without a try. Now, I lost my job, and I couldn't find one for 18 months because no one would hire a PA. I want to go back to medicine, and that's why I'm here today. Thank you very much.
Thank you, Representative. And of course, we have another former EM.
Yes.
You spoke to her, I'm sure.
Well, we start out in humble means, but eventually we find our calling.
Questions from the committee? Seeing none. Thank you very much.
Thank you. I'm here to answer any questions if you had any about scope of practice of PAs.
Thank you. Are there any other representatives in here that I didn't call on? Oh, Representative Palmer, I do have you here, okay. And you are Representative? All right, Representative Palmer, you're first. They have a busy schedule, so we try to get them out of here.
Thank you, Mr. Chairman and Senator. I'm sort of going to not do my whole spiel. My name is Bill Palmer. Represent Sullivan District 2 from Cornish and Plainfield, and I'm a practicing physician and I work in a critical access hospital, and we couldn't do it without PAs and nurse practitioners. And the prime sponsor alluded to an ER visit. Well, a bunch of my family members have ended up in our ER and had excellent care from PAs. I would like to see a compromise. What Dr. Nagel just spoke to is kind of where I feel like we need to make it easier for PAs to practice in New Hampshire, but I think this bill just sort of opens the floodgates. The specific thing, I look at the 8,000 hours, but it doesn't say, I mean, you could have 8,000 hours as an orthopedic PA, and then can you go out and practice in primary care? So I'd like to see this kind of thing looked at and tightened up. And that's I think, pretty much what I would add to what's already been said.
So have you worked with the proponents of the bill as far as
No,
the definitions? No, they have not.
No, I have not.
We got a week. Got a week.
Yeah. I still am nervous about not having a little bit more, few more guardrails on it. And I guess my point and what Senator Bradley was talking about is I'd like to see not a winner or a loser, but a compromise.
Thank you for your testimony. Appreciate your comments. A question? Seeing none. Representative? And your name is again?
Good morning, Senators. For the record, I am Representative Trinidad. I represent
You're fine.
Hillsborough District 40. I currently serve on the House Health and Human Services and Elderly Affairs Committee. I am a family physician, trained as a health services researcher. I teach public health students quality improvement. I'm former director of the Office of Health Equity and served many years on the Legislative Commission on the Interdisciplinary Primary Care Workforce. So I'm very committed to addressing workforce shortage issues and access to care for underserved communities and populations. I agree with many of the comments made by Drs. Nagel and Palmer. Physician assistants play a very important role in our healthcare system. They are important team members and in collaboration with their physicians provide excellent care. However, their training does not prepare them for independent practice. In addition to what's been covered, this issue of physician assistants not completing residency and collaborating with a physician who takes responsibility for their development and ability to practice within a prescribed scope is really important. Since the vast majority of physician assistants are practicing in specialty care, it could be expected that upon completing their unmentored 8,000 hours, that at least some might open their practices to provide specialty and perhaps even surgical care. Without any mention of limits on scope, this bill allows physician assistants to practice independently within any specialty area. In contrast, nurse practitioners are trained in their specialty and must demonstrate competence within that specialty in order to practice. Additionally, this bill fails to require any demonstration of competence in their skills. 8,000 hours of practice alone does not confer competence. The bill does not require the collaborating physicians to sign off on competencies, as we've been discussing, and this bill does not require them to pass a board examination in their chosen specialty. There's nothing in this bill that can assure the public, who has a very difficult time distinguishing any of their primary care providers or physicians, nurse practitioners, and physician assistants. The public can't be assured that the care they receive from an independent physician assistant will be safe or high quality. I'm sure we all share the fundamental value of safe, high quality healthcare in the Granite State. Trust is essential to the success of our healthcare system, which is built on a robust collection of policies and processes that ensure that care is safe and high quality. As legislators, we cannot pass policy absent of reassurances and safeguards through scope of practice determinations and demonstrations of competence for physician assistants. The public will have no reason to trust in the care they receive. We must do better for our patients and appropriately study this very important issue. I encourage you to vote ITL.
Thank you for your testimony, Senator.
Thank you, Senator Abard, and good morning. And, nice to see you. I'm usually on the other side of the table, so I recognize you. Okay, I have a question for you quickly on PA certification. You said doesn't require an exam in a specialty, but there is a PA certification, a board certification in general. But if they are specializing in, say, orthopedics, I know some folks are nodding heads. It's not, I'm just trying to narrow in and we'll get to you, but they're, say, they leave PA school, they then take their board certification, and then they're, PAC and licensed in whatever state they choose to work in, whatever the requirements are. Are you saying that if they have a specialty in orthopedics or cardiothoracic, whatever it might be, that there isn't a subspecialty exam for that?
That is
make
my
sense?
understanding. I will
Okay.
let other people speak to the details of that. I think the concern is everyone finishes PA school, goes and spends 8,000 hours or however many hours in different settings. But if there's no assessment of that specific scope, and they can then go out and practice anything, that is a concern.
Okay, thank you for clarification. Perfect.
I have a question. So,
I will attempt to.
doctor in New York signs something for a PA to practice in New Hampshire. $1,000 a month. Never shows up, never sees the patients, never has any physical being in the state. Yet this is a common practice, apparently, not necessarily, that's just one scenario. I'm not convinced that that's providing any kind of health care. That's, in my humble opinion, not a doctor, but that's just somebody signing something so they get $1,000 a month. Convince me that I'm wrong.
I can't speak to the changes that were made the last time around where now it's not supervision. I have always worked in settings where PAs or residents, everybody had someone else. Even I, as a completely independent physician, often searched out other people for questions and mentorship. So I can't speak to that. That's why I think it needs to be studied, because we don't know.
Well, we do have a shortage, and we're trying to solve a problem here with the shortage. And I'm not looking at that as though that's real health care. I don't know if you agree with me or not, but obviously we want to make sure that, you know, the patient has somebody that's competent, that's qualified, did the time. But if there's a patient out of state, a doctor out of state just collecting, not even seeing the patients, would you say that that's a problem?
Well, as a researcher, I would say I don't know if that's the norm, or I don't know if that's just one exceptional case. And that's why, again, I think all of the docs here have suggested this is rushed and we should study it. I teach quality improvement. I believe that data is what can inform. And like I said, I've been almost 10 years on the Legislative Commission on the Interdisciplinary Primary Care Workforce. We work very hard to think comprehensively of all the interlocking pieces, whether it's student placements for nursing students, or all the very many pieces that fit into why we have a healthcare shortage, and loan repayment, and all the other things that go into making sure that underserved areas are served. So I just, as Dr. Nagel said, this is very complicated, and I'm not sure it helps people to try to rush it through in 1 week.
I really appreciate your testimony.
you.
Thank you for taking the questions. Dr. Maria Boylan. And you heard my concerns too. I mean, if you can put that in there somewhere, that'd be great. In your testimony. Want to hit your button?
Oh, thank you. I'm a noob.
Okay. Sorry.
Thank you, members of the Senate Health and Human Services Committee. My name's Dr. Maria Boylan. I'm a New Hampshire resident. I'm a family practice physician, and I'm writing in strong opposition to House Bill 1222. I work in an outpatient family medicine clinic in Bedford with a multidisciplinary team that includes physicians, nurse practitioners, and a single PA. That PA I currently share a collaborative agreement with, and the hospital system that I work for employs dozens of PAs, mostly who practice in specialty care. They are an integral part of our healthcare team and our practice and the work that we do. But it is critical that they continue to have collaboration and support of physicians in their practice. I'm required to review and sign off on every one of their notes. I have to be available for questions that they may have. And sometimes I have to additionally assess or evaluate a patient that they're seeing, as well as provide yearly assessments and reviews. And that's something that my organization requires of their PAs. This is not universal to all PAs. I have grave concerns when it comes to allowing PAs to practice medicine independently. Currently, only 3 other states do so. And PAs, by definition, are physician's assistants, and their training reflects just that. Their training is inadequate to practice medicine independently without supervision or collaboration. And I'm going to name some specific examples. Comparison-wise, PAs only complete 27 months of schooling before receiving their master's degree. Doctors complete 4 years of medical school before receiving their doctorate. PAs do not go on to complete any residency type training, which is vigorous training in a particular field of medicine, while doctors complete 3 to 7 years of residency in their medical specialty, which is sometimes even followed up by another year of fellowship. PAs only need to pass a single exam at the end of their schooling, while doctors need to complete 3-step exams consisting of both written and clinical skills throughout their course of medical training, and an additional board exam in their fields of specialty practice with ongoing recertification requirements throughout our career. PAs only average 2,000 hours of clinical training before entering practice, where physicians have 12 to 16,000. And in Tom Sherman's case, he had 25,000 hours of clinical training before having the privilege to take care of patients independently. House Bill 1222, as amended, alters the current collaborative agreement requirement to a semi-requirement if a PA has fewer than 8,000 hours of clinical practice, but only in a setting where a physician is not employed. Under this proposal, if a PA works in a setting where a physician is employed, such as a hospital or practice setting with no collaborative agreement relationship with any provider, or minimum hours are required for a PA to practice independently. Can I continue to go?
Yes, I'll give you 30 seconds, then I'll ask you a question, and then you can have a time.
Sure. And depending on the amount of supervision or collaboration that PA has with their physician, their training or experience may not be high enough quality to ensure that he or she is capable of practicing in a safe, comprehensive manner. I also have ongoing concerns about the scope of practice, where one great example is if I suddenly wanted to be a cardiologist, I would have to return to residency, study cardiology under residency for another 5 years, take an additional board exam in that specialty, only to be able to switch. And this bill does not have any delineation of the scope of practice and specialty that they practice in, and they could decide to do whatever they wish.
So I have a question, and I don't know if you do, Senator, I'll get to you in a second. But with regard to your organization that requires you to sign off on everything as is, does this bill prohibit that from, does this interrupt that? If the organization says you need to sign off everything for the PA?
The bill states that the health systems can continue to have their own requirements, but I think it would disrupt the entire healthcare system. And without the hospital association at the table talking about this as well, it could, greatly affect how they hire PAs and retain PAs. And I worry that it could also lead to PAs leaving our healthcare systems where they're desperately needed to go practice independently.
Mm-hmm. Questions? Well done.
Okay. Thank you so much.
You're very much. And if you can leave that with us, and we'll make copies.
Yep, I passed it around.
Oh, you did. All right.
And just for clarity, I included the Board of Medicine statement on this bill that they are not taking a position at this time. So
Thank you for your testimony. Dr. John Kropp. Dr. John Kropp.
Eric Crop?
I beg your pardon? It looks like John to me. J. Okay, it just says
I think it was the
John.
doctor's handwriting when they. So I apologize.
Does that look like a John to you? Up here.
Yeah,
Apologies.
That's all right.
Jon and JOHN, so we're good. Yeah, thank you.
Doctor? You have
Oh,
the
shall
floor.
correct the record. Eric Crop.
Eric, okay.
Yes.
Welcome.
Thank you. Thank you to the committee members for hearing my testimony on this bill. My name is Eric Crop. I'm a resident of New Hampshire. I'm a family physician and New Hampshire Medical Society council member, and I strongly urge you to vote ITL on this bill. I'm a family physician practicing in Concord. I've taught medical students, residents. I've mentored PAs in my own family practice, worked collaboratively on teams in urgent care settings, specialty settings during my training. I share many patients with many excellent PAs as part of collaborative teams in specialty practices. I've had excellent experiences with PAs. I've been in practice for 15 years. Prior to that, I did 3 years of training at Dartmouth Family Medicine Residency. Before that, my 4th year of medical school were clerkships throughout Chicago. I guess if you add that up, it's really more like 18 or 19 years, but I don't see it like that. It wasn't until the end of my 3rd year of residency that I really felt that I had the skill, that I was prepared, that I had the insight and understanding to really safely be able to practice independently as a family physician. The reality is that nobody's prepared after 3 years of medical education, be it medical school or PA school, to practice independently, especially in the full scope of medical care. So when is somebody ready to practice medicine independently? It's a good question, and there's been some talk of that. My take is that residents go through a highly structured, highly regulated training program with strict supervision to ensure patient safety and the quality of that education, followed by the licensing exam. It's something of a joke that you should never be admitted to a hospital in July, because that's when the new class of interns starts on July 1st. The reality is, those interns are the most supervised of all medical practitioners
I'm gonna
across
make a
medicine.
note of that. Good.
So the way physician collaboration works with PAs should mirror that sort of supervision to allow them to gain that experience, that knowledge, build on their schooling during that time. And what I've heard is that physician assistants are not receiving that in the collaborative agreements that they're signed on to. The solution is not to eliminate that requirement. That would be akin to eliminating the residency requirement for physicians. And there was a House Bill 1427 that got defeated just recently, and I think a couple of years prior, Dr. Morse had put one through, which would have created a deputy physician status for graduates of a 4-year medical program. That was clearly defeated. People said, no, physicians need to go through a residency program. They need to train in order to practice. This is doing the same thing for physician assistants, saying you don't need any supervision, you can go free. May I speak just very briefly on the scope of practice issue? I'm going to add slightly another word to what's been defined. PAs practice a very broad scope of practice, but they don't do so independently. They do so under board certified residency or fellowship trained specialists. This would allow them to go out and practice independently, a very broad scope of practice. I couldn't do that. I would need to do a residency. And I think that we need to ensure for public safety that everybody, whether you're rural or in urban Concord, receiving the highest level of care through people supervised to the appropriate level of their training.
Thank you for your testimony, but I do have a question.
Yes.
It goes back to what I asked again, because you brought up public safety. You brought up the care. There's a concern, but when somebody is out of state and they're signing on that certificate, yep, and they never step into the room to look at the patient, something's missing here. That's not healthcare. Well, the PA's doing it, obviously, but the doctor has absolutely no say in what's going on other than collecting that check. And
if you're asking my personal opinion, I think that is inadequate supervision.
Thank you.
And I think that the solution is not to further remove safeguards. I think the solution is to further define what is adequate and address the question here, which is, or what prompted this bill was PAs who have achieved a certain level of competence, who've practiced a certain scope, at what point can they practice independently? And that's a very different question than is being addressed by this whitewash of elimination of all the safeguards.
So how are we doing with PAs in the state? Are we losing them or are we gaining more?
I don't have that information.
Question?
I do, and I actually have that. I think that might be for somebody else. We need to have a better understanding of the layout, including the North Country. But we heard from another representative that the entire state has a shortage. Eric, Doctor, Eric John.
Eric John.
Yeah, it did say John. So
I'm just gonna call you doctor.
just for clarity, it's my understanding right now, based on the law change that I believe Senator Sherman said was in 2022, that there is phone supervision now allowed versus the direct. We're in the same office. I come see you, and that was put into place to create more opportunities for access to healthcare in different settings. So there is this phone construct. Is it your position that as it is not enough?
No, not inherent to the design of phone contact. There's a lot of medical care that can be provided directly over telephones and telemedicine and telestroke programs or
time,
contact. But lack of supervision is problematic by any means, whether they're next door and not providing oversight, not being available. That's problematic, whether they're on a telephone and not providing that supervision or that collaboration, being that resource, being that mentor. That doesn't work for me. And this is from somebody, all of my family are educators. John Kropp is actually a teacher. He's my cousin. But I take education seriously, and I precepted residents. I currently am faculty at Dartmouth and precept first and second year medical students. Medicine doesn't happen in a vacuum, and we don't learn in a vacuum. Medicine has always been an apprenticeship. It's always been passing down, and that has to continue even in the days of Google and all the plethora of apps that are out there to help with medical decision making. Nothing replaces experience, and you gain that experience by learning from the experience of others, by having one experience and then your mentor brings in the others, just as Dr. Sherman was talking about. That's critical. And if that's not happening, that's a different problem than saying that mentorship shouldn't happen. It absolutely needs to happen. That's how medicine grows.
Okay. Thank you very much. Appreciate it. Dr. George Latirio. Did I get that right? Yes, sir. All right.
Should be. Like, okay. Good morning, members of the Senate Health and Human Services Committee. My name is Dr. George Latario, and I'm one of the senior residents about to graduate from the New Hampshire Dartmouth Family Medicine Residency Program here at Concord Hospital. I'm here today to express my strong opposition to HB 1222. When reviewing House Bill 1222, I am concerned about the lack of requirements for physician assistants to practice independently in any given field of medicine. I, along with many other physicians, take a long and extensive journey to develop our skills and receive an education in our various fields and specialties. After completing my undergraduate degree from McMaster University, I then spent over 4 years researching and completing my medical degree. At this point in my career, after spending over 8 years of my life to become a doctor, and despite earning a medical degree, I was not allowed to practice patient care without completing a residency. By the standards set forth by House Bill 1222, a physician assistant will be allowed to practice without a collaboration agreement so long as they are in the same healthcare setting as a licensed New Hampshire physician. Furthermore, if a physician assistant finds themselves in a healthcare setting without a licensed physician, they require 8,000 hours of clinical experience before they can practice independently. I feel compelled to call your attention to such a disparity in education and training requirements. By comparison between medical school clinical rotations and residency, I've amassed well over 16,000 hours of clinical experience. Mind you, this is only for the specialty of family medicine. Should I wish to pursue a different field of medicine, such as surgery, oncology, urology, neurology, I'd have to complete an additional residency and subsequent fellowships. This can range anywhere between an additional 3 to 7 years of training. This bill does not set forth what would be expected of a physician assistant should they be able to independently practice and wish to switch specialties. Like supporters of this bill, I am very passionate about increasing access to care to the people of New Hampshire, especially from a primary care standpoint. In fact, 7 of my fellow residents and I have decided to stay here in New Hampshire to continue practicing after we've completed our residency in June. And while physician assistants and physicians agree on the importance and true need for increased access to care around our state, I do not believe House Bill 1222 will be effective in providing a standard of care the people of New Hampshire deserve and expect from the medical community. For these reasons, I, alongside countless other physicians, the American Medical Association, and the New Hampshire Medical Society, urge the Senate Health and Human Services Committee to recommend inexpedient to legislate on HB 1222. Thank you for your time and consideration.
Well done. One of the senators, actually the chairwoman, brought up a good point that one of the reasons that this bill was brought forth was because PAs were being laid off and doctors weren't signing off on their contracts. Are you aware of that?
Sorry, can you repeat the
PAs
question?
were being laid off and doctors weren't signing off on their contracts. So creating a shortage of PAs in the state.
I'm not aware of that, but I will say that currently, so myself, I signed on to join the Belmont practice. I'm one of the rural track residents of practice out in Hillsborough for my training. My wife is actually from Lancaster up in North Country. But the Lakes region is another area that has a shortage. And so when I signed on for Belmont, part of early on in my residency, I was contacted to let them know that there is a PA that was going to be joining. And so I actually got to partake in his interviewing process, and we did hire him because I thought a collaboration with him would be appropriate. So I'm unfortunately, I can't speak specifically to that question, but from my personal experience, I'm willing to work with any PA.
Perfect. Questions? No. Seeing none. Thank you very much, Doctor.
Thank you for your time.
Appreciate your time. Ruth Culligan.
Oh, thanks. Hello, my name is Ruth Colligan. I'm a resident of Concord. I am a physician that's retired from clinical practice. I have a master's in patient safety, and I'm a peer-reviewed author in patient safety and systems engineering. Currently, my work focuses on medical malpractice. As a patient and a professional, I oppose House Bill 1222. In September 23, I was a patient at an orthopedic clinic in a large professional practice that employs many PAs. I saw a PA who misdiagnosed a finger sprain. Several weeks after, I saw a hand surgeon who diagnosed a ruptured tendon. By then, my injury was over a month old, and my finger was too stiff to ever regain full function. I needed 2 surgeries and 40 hours of occupational therapy to regain some function. Every morning, I have to do 20 minutes of exercises to get my finger moving. So my right hand, my dominant hand, is permanently disabled. For the record, I received this treatment under New Hampshire's collaborative model for PA practice effective August 22. I followed up with practice management and brought a complaint. I had many questions, however, chiefly as to why this PA assigned to my care did not consult a hand physician after he received 3 messages from me that my hand was deteriorating. Eliminating the collaboration agreement requirement will take away the need for practices to reflect upon their deployment of PAs. I would implore this committee to allow the collaborative model implemented less than 2 years ago to continue and allow time for outcomes under this model to work their way through the system. I'm just one patient with one bad outcome. I fear with the passage of House Bill 1222, we may see more bad outcomes in our state. As a patient, and especially as a physician, I know healthcare isn't perfect, but I don't want other patients to experience the poor medical treatment I did. New Hampshire patients deserve better. Please vote inexpedient to legislate on House Bill 1222. Thank you for letting me speak, and I'll take any questions.
Questions from the committee? Seeing none. Thank you very much, Ruth. Rachel Zeno? I got one right. And you're on.
Good morning, Mr. Chairman and members of the committee. My name is Rachel Zeno.
Closer, a little.
Closer.
No, pull the mic closer to you, just a little.
Oh.
Yeah. That's,
Is that better?
yeah, perfect.
Okay, great. I live here in Concord, and I'm a physician assistant student at Franklin Pierce University up in Lebanon, New Hampshire. And I'm speaking on behalf of myself in support of HB 1222. Before PA school, I worked as a medical assistant here in New Hampshire with a group that included 1 physician and 2 nurse practitioners. There were no PAs in the practice, and of course I asked why, and I was told it was due to the added administrative and cost burdens placed on an employer who makes hiring decisions. This highlights the necessity of passing this bill as it removes the legal tether that is limiting PA employment in New Hampshire. When I graduate from PA school, even though it is a very rigorous program, I realize that there will still be more to learn from physicians and all members of my new healthcare team. I welcome the wisdom that experienced providers can offer me and my future patients after I graduate. And when I chose to have a career in healthcare, I chose to be a perpetual learner. And this is one of my favorite aspects of science and medicine because it is ever evolving. And my learning doesn't stop once I get a diploma. When I graduate, I will be a PA who's driven by quality patient care and safety while complying with all the legal and workplace requirements, regardless of whether or not there is a written collaboration agreement with any physician. Because my husband and I chose to move to New Hampshire from North Carolina just over a year ago to pursue my PA degree here, it's because where we want to live. We want to live and stay in New Hampshire and work in New Hampshire for years to come. And my fear is that when I graduate, surrounding states will have far more and quite frankly, far better practice environments for PAs compared to New Hampshire, and we'll be forced to reconsider where we call home. I have immensely valued working with physicians over the years, and I'm also disheartened by the ways PAs have been and continue to be discussed by physicians. And this rhetoric erodes the collaborative relationship and gives me significant concern for future PA practice in the state of New Hampshire. Both of these things are likely to exacerbate provider shortages and thus increase barriers to healthcare access for residents of New Hampshire, which is already a state predominantly categorized as medically underserved. So I want to finish by thanking the committee, you all, for your time, and I'm happy to answer any questions you may have.
Well done. Seeing no further questions, thank you for your testimony.
Thank you.
Dr. Colin Arnold?
Thank you.
Welcome.
I am Dr. Colleen Arnold.
Colleen.
I'm a New Hampshire resident and practicing physician of 21 years here in New Hampshire. I thank you for the opportunity to come before you to voice my opposition to House Bill 1222. As a former physician assistant myself, I have a unique perspective regarding the training and medical practice of both professions. I received my PA degree from Yale University and then practiced in rural areas of Oklahoma with the National Health Service Corps and the Indian Health Service. For the first 2 years out of PA school, I practiced nearly independently as the community health center I was assigned to lost the physician who would have been my supervising physician. This was far from ideal, and I was in no way prepared for this. At that point, I felt I could do so much more for my patients, but I was lacking in the tools to do so. So I started the process to return to medical school. The next 2 years I spent as a PA in an amazing collaborative group practice with family practice physicians and pediatricians in the Indian Health Service. My confidence and clinical knowledge grew exponentially. I was accepted into medical school, but was dismayed that after 2 years of PA school and 4 years of working as a PA, that I still had to complete the 4 years of medical school. So that's 8,000 hours. That's what we're looking at with PAs who are not working directly with a physician. Surely some of what I had learned would have counted towards medical school. I expected to sail right through, but it was not a piece of cake. I attended 4 to 6 hours of class daily, followed by 4 to 6 hours of studying every night. The depth of knowledge in medical school was beyond what I expected. I learned I didn't know what I didn't know as a PA, and that significantly impacted the care of my patients. PAs have 2,000 clinical hours in training, Physicians have, as you've heard from many people here, 15,000 hours by the time they finish both medical school and a 3-year residency, all supervised with increasing levels of independence. This does not happen in PA clinical curriculums. PAs are not trained to practice independently. One of my concerns with House Bill 1222 is that PAs who work without an employed physician can gain autonomy after 8,000 hours or 4 years of collaborative agreement with a physician. That's, again, nearly what I described to you when I returned to medical school, and it in no way prepared me to take care of my patients safely. I see a lot of similarities between paralegals and attorneys and PAs and physicians. Both are really good at what they do. In 2022, Governor Sununu signed into law the New Hampshire Paraprofessional Pilot Program. For those who don't know what that is, I didn't know what that was. This allows paralegals to practice law for underserved populations under the supervision of attorneys. I ask you why we are so cavalier with the health of Granite Staters while so conservative with their legal representation. I thank you for allowing my testimony.
Well done. Questions from the committee? Seeing none. Thank you,
Thank
Doctor.
you.
Appreciate it. Sabrina. She left? Okay. All right. And Jonathan Gott. Did I get that right?
You got it.
All right. I'm
Is
just
handwriting not
questioning
great?
myself these days because I'm a little dyslexic. So
I think you got it. Okay. Thanks.
You have the floor.
Is this close enough?
That's fine.
Perfect. Hi, I'm Jonathan Gott. I live in Manchester, New Hampshire. I've been a practicing PA in internal medicine and more recently addiction medicine, homeless care medicine, and urgent care. I just did the rough math and it looks like I have about 27,000 clinical hours. It seems like there's quite a lot of repetition today in objection to this bill regarding the training of physicians versus physician assistants. And that's an important question. It's an interesting question when you look at how do people become competent, but I don't think that's what this bill is about. This bill is about allowing what's already happening to happen more easily, to allow physician assistants to be employed more easily, as opposed to suddenly making them change everything that they're doing and putting everyone at tremendous risk. That's not what it's about. And I'm moved to ask, is there an epidemic of mortality or morbidity increases with physician assistants currently in the state of New Hampshire? I did look up some data, as I do because I'm a big nerd. There's no such data for that. They had an article in the New England Journal of Medicine, nurse practitioners and PAs with physicians versus nurse practitioners and PAs, with residents and physicians, and morbidity and mortality were the same. There were what I found was interesting was there was more referrals from physician assistants and nurse practitioners in that group dynamic. And that's the point I'd like to highlight is when you practice medicine, you know what you know and what you don't know. So the idea that suddenly someone is, PAs are going to be practicing medicine in a way that they don't know how to and injuring Granite Staters is not something that I'm willing to go in on. You know what you know and what you don't know. I was trained for many, many years by wonderful physicians because when I graduated, I certainly needed that help. And that was 12 years ago. And I couldn't help but think, when Dr. Carrier didn't know what to do, he would refer to neurology, or he'd refer to psychiatry, he'd refer to thoracic surgery. And the fact that he was an independent practitioner was not suddenly making him practice thoracic surgery or practice outside of the scope of things that he knew how to do. So I'm not sure how this bill is going to suddenly injure Granite Staters or make things more difficult. I think it'll only increase access to healthcare, make it easier to hire us, make it easier for us to do what we know how to do and can do. We all have things to teach each other. We all have different skill sets. At the hospital that I work at, I'm the outpatient addiction provider. I am the only one. I was trained by a fellowship addiction physician. And now all the docs and everyone call me when they need something and when they need a consult. My personal experience with this is for 12 years, I've always been anxious that I'm going to suddenly be without a job. When I started, the physicians who were on my agreement, they didn't want me to see anyone else. And they loved me and I loved them. And they trusted me very, very well. And they did not review everything I did, by the way. That is not how that works, may I? And then they left. In fact, we're losing so many MDs and DOs in primary care. We're lot of APPs, advanced practice practitioners. And last time someone left, I was unclear if someone else would sign on to my form. I hold a panel of 700 patients, some of whom I've known for 10 years, and they were going to lose me as their provider. They're going to lose that continuity of care. Nobody knows them like I do. And I was going to disappear if someone didn't sign the agreement. And then the collaborative agreement came out, right? And I breathed such a sigh of relief because so clearly in that newest collaborative agreement, it states if John sends someone home with an MI, so excuse me, heart attack, and they die and no doc was aware of it, John gets sued and nobody else does. So I thought, wonderful. This is appropriate. No one trusted that very plain language. I mean, I guess it's without legal precedent. I'm currently working at a small addiction practice, and the doc is very old and would love to retire, but he can't because no one else will do it. And I know we've sort of brought up these collaborative agreements. I know you've asked about it, Senator Rivard. I looked into it. $30,000 for one. The cheapest I could find was $12,000 per year, and they would not budge on that. And I said, I know what I know and I don't know, and I know to refer when I don't know the answer. And I do not need $12,000 or $30,000 of help. Thank you.
Questions from the committee? Well done. Thank you
you.
very much. Oh, yes, you do.
Oh,
Sorry. Hang on.
So thank you for taking my question. And
Of course. Thank you for being here.
I understand the first part that you brought up, and I want to just kind of set that aside to actually focus in on something that came up with the prime sponsor of the bill, which I think is the crux of this, and it's barriers to employment. So what I'm trying to understand, and you just described a situation where a physician or a practice ended or left.
The person who was on my paperwork left.
And you were essentially untethered.
Correct.
Is that the only barrier to employment for physician's assistants in terms of relationship, the more traditional relationship?
Relationship with an employer or with patients?
Not with patients, with the employer.
I believe that is absolutely the primary barrier. In fact, speaking to our recruiter at the hospital, she puts out for NPs, and I said, why don't you put out for PAs? It's because people are anxious about signing my paperwork and getting sued for something that they were not involved in. I can't blame them at all for that, by the way. So that has been a significant barrier to hiring new PAs in our practice, according to our recruiter.
Okay, thank you.
Thank you.
Well done. Thank you. Nick? You're the only Nick.
Thank you. You hear me okay?
Yes, we can.
Glad to be here. Thank you very much. I'm representing being old and being ancient in some ways and having a past history. So I'm here on myself, but the Medical Society has urged me to talk to on this topic. I am a retired, semi-retired general surgeon here in Concord over 30 years. I'm semi-retired because I still teach medical students from Dartmouth, third-year students. Somebody brought up third-year medical students training. And I work closely with getting these students educated with PAs and nurse practitioners. A couple times a week I work with them. The other past history that ended 5 years ago was I was on the New Hampshire Board of Medicine in various capacities for about 17 years. It had a medical review subcommittee that existed for 40 years. It kind of ended this summer. And I was physician investigator for 5 years. That kind of ended this summer. There's a lot of changes happening with OPLC and the Board of Medicine. And that's one of the bills that's out there, H322. Different subject. At the Board of Medicine and in the review committee, we always had a PA going back 40 years because that's when it kind of got started. And the PA was very much a force on that board, had a full vote on all the doctor issues that came up. And when there was a PA issue, it got investigated. And it was double work for the investigative committee because you had to investigate the PA and at that time wasn't collaborating, it was supervising position. And you're right, it often is not that doc when something bad happens. At least a third of the time in 17 years of looking at all these cases, the physician assistants, I wasn't there that day, yeah, I signed the thing, but I'll help you find who was on call at that point or who was on call for me, even if this was a small practice. So we would spend time digging up 2/3 of the time who really was involved. And we didn't get pushback. And so when that investigation happened, and if it went to a hearing or sometimes civic trial, there was always a physician and a PA there. Okay, both together. They were melded together. And I do want to answer your question about the $1,000 in New York at the end, so hopefully I'll be quick. What I heard so far today, I was impressed with the sponsoring bill's initial testimony. I was delighted that he had communicated with an attorney from the Board of Medicine, maybe the executive director, maybe the doc who's head of the Board of Medicine. Speaking of doc of Board of Medicine, in 2012, I was one of the 2 candidates to be the head of the Board of Medicine, and I was beat out by a PA doc, and thank God, because he did a hell of a lot better job than I ever would have done at that point. And we've had several PAs who have been head of the Board of Medicine in the past. I don't know if you're aware of that. Getting back to how it worked is that you always had that connection. And when bad things happened, there was always that connection, both in investigation and even at the civil trial. And at the civil trial, you'd have to have an attorney there, obviously. And the attorneys, I would hope that this committee would talk to the plaintiff attorneys that protect patients, so to speak, because they may have a reluctance to helping a patient if the PA basically is on their own without a doc there. They're interested in deep pockets when they go after a doc who's done something wrong or a PA that's done something wrong, and that may be different. So I'm hoping that this group, and I was sad to hear Senator Bradley say that this is going to be one or nothing. I really agree with Dr. Nagel. I'm torn on this. I think this is a battle between access and safety. And I really worry about the safety part. I don't think there's much of a turf battle issue here. I think it's safety. And I would hope the Board of Medicine, if it continues to have a PA in its realm, needs to increase the number of PAs on the board if they're going to do this, rather than, because the mechanism was different. It would have to change it. And I would hope at the same time plaintiff attorneys would have the opportunity to see what they think about this kind of change. And I would hope PAs themselves would look carefully what malpractice insurance may change in the future, because that's a safety issue.
So one of the senators did bring up the fact that the reason this bill came in is because doctors they're reticent to sign off on PAs. So now we have a shortage. And of course,
and that was true in my day, and that's correct.
Yeah. So how do we fix that?
Pardon?
How do we fix that?
Well, it'd be nice to force them to sign, in my opinion. I mean, if you're at a hospital setting, you're going to have, in an ER hospital setting, the ones I work with, that's kind of an automatic deal. You all have to sign on to be contracted. And you all have to have malpractice insurance working in a hospital. You know, if you're an independent nurse practitioner, I don't think you have to have malpractice. Maybe nurses, but I know that docs in the state of New Hampshire, to get licensed, don't have to have malpractice insurance.
There's not like an umbrella policy or anything like that?
Nothing in the state of New Hampshire. You can get a license without having malpractice insurance in New Hampshire. That's still true. I've had a license for 40 years in Massachusetts, and I've always had to document my malpractice insurance, even teaching that I do today.
Do you see a room for compromise on this?
Absolutely. And what Dr. Dangle was talking about really hit home. I think the access is a real issue. That's why this bill is here. And I think these young folks back here, I assume are all PAs, want to help out. But how do we make it safe for the patients? Because that's the ultimate role of the state government, isn't it? The Board of Medicine and so forth, to make it safe. So maybe changing the nature of the Board of Medicine, working that out, working with plaintiff attorneys, working that out would be the answer. But I think time is important here.
So you said you were going to answer my question on the New York situation.
So again, I'm ancient history. I quit in 19 before the epidemic, and OPLC changed a lot of stuff then. But if there was, you could have a collaborative doc, we call it a supervising doc from out of state, but they had to have a New Hampshire license too. So my big question is, that guy in New York or that woman in New York who's getting $1,000 or $30,000 a year, whatever, do they have a New Hampshire license? And then that PA could then complain to the Board of Medicine, and that doc could lose his license, because that's not just a care issue, that's an ethical issue. That's an ethical issue. You can't be charging somebody for this. So that I'm amazed that that exists. I'm assuming it exists, but I would hope under the collaborative agreement that happened in 22 that we didn't make that possible. You could have someone on a phone from out of state and they did not have to have a New Hampshire license. That's a setup for this kind of problem. So that's my big question. Did that New York doc have a New Hampshire license? because he should be beaten up if he has a New Hampshire license to be able to do something like that. And boards of medicines communicate with each other. He'd have a problem in New York too if he just had a New Hampshire license, New York license. Sorry to go over time.
No, I invited it. Questions?
Sure. Thank you for taking my question, Doctor. Malpractice insurance, so not required,
Not to have a license in the state of New Hampshire.
but do you, so follow up?
Well, yeah.
Do you know any practicing physician, nurse practitioner, or PA that would work without it?
I think it would be crazy.
Yeah.
And not only crazy, but unsafe for the patients. And I think the plaintiff lawyers will tell you the same thing.
Thank you.
Seeing no further questions, thank you. An attorney just stood up. Uh-oh. Do you want to talk? Oh. Sabrina? You're right. Thank you. Let's see. Sarah. Smile. There you go. It's a song. Yeah, you gotta. I can't help myself.
Good morning,
Welcome.
Chairman and members of the committee. For the record, my name is Sarah Leslie. I'm the Vice President of the New Hampshire Society of PAs and the co-chair of the New Hampshire Society of PAs Advocacy Committee. I'm a licensed PA of 14 years and I live in Deerfield. NISPA represents the 1,000 PAs in the state and 71% of them are women. We have the two PA schools, Franklin Pierce and Mass College of Pharmacy. We obviously support HB 1222. We provided the committee several one-pagers looking at the scope of practice, comparing the myths and facts of PAs. But I'd also like to briefly address some misconceptions around the bill. I keep hearing the word independent being used. It's not true independence. Yes, whenever we're in teams, we don't have the collaboration agreements. When you're employed. So if I'm working in the hospital or if I'm working in the urgent care. Yes. Oh, I'm sorry. Is this better?
That's better.
I'm sorry.
Yep.
We have physicians around. We have people that we can talk to. Even when I was in the ER, I never worked with my actual doc that was my supervising physician and then my collaborating physician. I never worked with him because he was the director. But I always, if I had questions, I would go talk to physicians or other PAs, whoever was working, if I felt that it was something that I wasn't sure about. But for PAs that have the 8,000 hours that we keep calling independent practice, it is not, because in the statute, there are safeguards saying that that PA cannot work unless there's somebody, whether it's a physician or another healthcare team member, that they can access to ask questions, excuse me. So that's not true independence, because we are still, it's not a piece of paper, and that piece of paper is that tether. That's what's causing the issue. But we are still by law required to consult and refer if it is medically necessary or if it's beyond our training and experience. And our scope of practice is not changing. I was hearing before that our scope of practice is in the collaboration agreement. It is not. It is in the statute, and we are not changing that. And actually, we are adding in that language saying that you still have to consult, collaborate, and refer. I'm actually the PA that has the doc that is charging me about $1,000 a month, and I can provide those receipts for you, and I will happily do so. The doc is in Pennsylvania. He is licensed in New Hampshire because IMLC, the compacts, allow him to be licensed in a bunch of different states. Because what's happening where PAs are having a hard time getting these collaboration agreements or in some states supervising agreements, there is a cottage industry that has been created where these docs are now joining companies and they're creating their own little company and they are charging outrageous prices in order to get these collaboration agreements signed. I had no choice because I was talking to different docs here and everybody's like, well, my license isn't for sale. What other choice do I have but to go online to these companies that are now popping up all over the place where a doc will never step foot in my business or step foot in the practice of where I'm at, whether it's urgent care or wherever I might be, I'm now stuck paying this outrageous fee. But we hear PAs versus NPs, or PAs versus physician. This argument is not about PA versus physician. We are not physicians. We are PAs and we are proud to be so. We know we are not physicians. We know that our education is not the same as theirs, which is why whenever you are in a team, you don't have the collaboration agreement because you have all your team members there that you can work with and talk to. But this is about giving us parity with our similarly trained NP colleagues who have practiced for 20 years in the state, and there has been no bad outcome when their actual tether went away. They practice good, safe medicine, and that is exactly what PAs want to do. We're going to practice exactly how we always have. If you're in the ICU in surgery, you're going to practice with your physician. You're never going to be able to open a specialty care because you have to have malpractice insurance in order to open that. Oh, you have to have malpractice insurance. PAs are the only ones that are required to have it. And you cannot open up a specialty care practice if you're not a licensed dermatologist. Guess what? You're not going to be able to open. Malpractice isn't going to give you, give you your certificate. Well, by law, we have to have it. So I guess I will stop there for the moment because I know I somehow lost 3 minutes of time.
No, you're good. Sarah, do you have a question? No. Okay, Sarah, you heard what Dr. Nick said, and he was on the Board of Medicine.
Yes.
Is there room for compromise here at all? I mean, is there something that you could draw out of his testimony that you could work with?
When we're looking at PAs missing out on employment, because like what we were, Family Practice Foundation Medical Partners, we spoke to the director of the primary care department. They let go of the majority of their PAs because the docs left and they won't sign the agreements. When we're looking at the broad spectrum of PAs that are in hospital teams, there's no way to have a collaboration agreement, like a compromise there, because it is that piece of paper that stops us from being employed, whether that's for the rest of our lives or for 2,000 hours. It's a disparity between us and NPs.
So why didn't the doctors want to sign off?
Multiple reasons. They don't want the extra liability. And we thought we fixed this in SB 228. We thought we fixed all these issues. But what happened was we started hearing from PAs that this didn't fix anything, because we put in there that PAs are no longer, or the physician is no longer responsible for signing off on, or for the care the PA provides, but they are, unfortunately. They still get sued, so the hospitals still have to pay for a rider for them. They still can get pulled into the lawsuit. Will they fall off once they found that they weren't involved in the care? Sure, but there's still liability, so they don't want to sign them.
So how does this fix that?
We are now allowed to be part of the team and collaborate with them just like we always have, to learn from them, to learn from each other.
What about the insurance?
The malpractice insurance doesn't change. I mean, if you're in a team, most of us get our insurance from the hospital gets our insurance for us, and and the urgent care where I work at. And if the nice thing is actually the malpractice insurance is actually a safeguard, because then you can't go out and we'll go from orthopedics and open up a dermatology practice, because if you can't show the malpractice insurance that you have that education, experience, and training, they will not give you a certificate. So you can't just go do that. So you'll still be able to get your malpractice insurance. This doesn't change that. But it actually is a good thing, because it does stop some of the concerns that people have brought up. And you can't just go and open a specialty care practice, nor would a PA. NPs have been independent for 20 some years, and they haven't gone and opened up urology practices and surgical centers and all these things. So to think that a PA with our ethics that is so ingrained in us to be part of the team to go do something like that, especially whenever we have great evidence with our wonderfully trained NP colleagues, it's kind of absurd.
Any further questions? Seeing none. Thank you very much, Sarah. Appreciate it. Did I call him? I'm assuming this is Pedoa? Pedoa? P-E-O-O-A or P-E-D-O-O-A? Okay. Stephen Alexandros. You're going to yield it? You're going to yield that 3 minutes? You're here. You support the bill, though, right? Do you have written testimony?
I can submit it.
We'd like that. Thank you. Jennifer Ferreira. She left. Well, she was in support. Christine? Doesn't say whether you want to talk or not, but it just says in support. Christine Hawkinson. All right. Moving right along. I think I got everybody. What's your name? Yeah. Where are you? Oh, this one. Yeah, it says you didn't want to talk, but go ahead. Phone up. You don't spell your name John, huh? I got it on paper. It says John. Welcome, Gary.
Thank you for your time and indulging me. I appreciate your time. My name is Eric Plumbing. I'm a resident of New Hampshire. I've been a PA for a little over 25 years. Although I'm essentially retired, I remain on a per diem status with the hospital that I worked at. Throughout my career, I've always concentrated in surgical specialties, most recently thoracic surgery. And I just want to echo a few things. First, that one of the things that's hammered into us is that we don't know what we don't know, and that you may be seeing something that it just doesn't fit the mold. It just isn't quite right. And our first thing to do is to go ask someone, because again, we don't know what we don't know. So it is such an ingrained feature in our training to collaborate with physicians that we work with and other PAs and other members of the healthcare team that, again, as the previous speaker had mentioned, the idea of a PA going out and practicing independently, hanging a shingle out on a casual basis without having something to back that up, I see as just as inconceivable with the PAs that I've known over the course of my career. The administrative burden and the decreasing utilization of PAs in many practices like primary.
Pull the mic up a little closer.
The administrative burden associated with having PAs in practices, particularly in high volume practices, primary care and ERs and such, and the decrease in employment of PAs in those practices. I have seen that over the course of my career. People have given examples of Southern New Hampshire primary care laying off PAs and hiring a bunch of MPs. But a lot of that and a lot of the fears over the collaboration agreement or the lack of a collaboration agreement going away, I think can be addressed on an institution by institution basis. An institution doesn't have to require that every single chart gets signed off on. When I was out of school, the first 3 or 4 years that I was out of school, I worked for Dartmouth, and none of my charts were signed off on. But many of my cases were reviewed on a one-to-one basis with one of the surgeons I was working with, because the patient needed to be admitted. I had to talk with one of the docs and say, hey, I've got somebody here with what appears to be appendicitis. We need to do something about it. If the patient is going to be discharged, or if there's something going on with rounding, I needed to talk to someone and get these problems solved and get them to sign off on it. So the idea that collaboration is no longer going to be there is, it just, I don't see that as being a realistic thing over the practices that I worked in over the course of my career. What would be nice is if physicians didn't have to sign off on every single note, co-sign every single note, because when they hire an MP, they don't have to do that. And that at my hospital was a problem. So if this somehow helps to bring a little bit of parity and a little bit of decrease of that burden, it's not going to change how people practice and how they collaborate with the docs that they work with or the other PAs they work with, but it helps to even that a little bit and decrease the misery that some of the docs out there, where the rubber meets the road. Then I see it as a win-win all around. So.
Thank you for your testimony. Questions from the committee? Seeing none, you're our final speaker. Well done.
Yeah. I'm not much of a speaker, but.
Senator, can I address a couple things that were mentioned?
Very briefly.
Very briefly. Thank you. I know you have no obligation to do that, so I appreciate this. Just one of the things I know that was mentioned and questioned is, talking about working together. September 21st, I reached out to the Medical Society and said, I got this bill coming, and I don't want to cause trouble. I want to make sure everyone's at the table to get things done. And I've even though I'm a freshman, I've done this. I've been down here before. And
That's how senators do it.
Yeah, you believe that?
Huh?
You don't know what you're saying there, but so anyway, So September 21st, I wanted to get everybody ahead and let's solve the problems ahead of time so we can bring this to the legislature and fix it. I was told we're not going to support the bill. And I was told that by a couple of organizations that we're not going to support the bill. I said, well, all right, well, I'm going to represent my constituency. Had the hearing, testified. We're not going to support the bill. My phone didn't ring. Nobody called and said, hey, we want to work with you. Let's work. I have been more than willing to do this. So it gets through committee, passes out of committee. I shouldn't say was not unanimously, but then we go to the House and we were hearing some things. Well, we need experience and the criticisms of this profession versus the other one. And it was, because the last thing I wanted was a turf war, because I work in the space and I know how that is. So I said, well, all right, well, I listened to the chirping and we put the floor amendment in. We put the floor amendment in as Representative Lekis said. We kind of addressed those things. The floor amendment passes on a voice vote. The phone didn't ring. Nobody's saying, hey, we need to work on this. We need to make this better. You know, for those of the folks that have worked with me here in the legislature knows I'm a pretty easy guy to get along with, and I really work for some good common endpoints. You know, I heard yesterday, you know, hey, you know, what can we do to make this better? Can we send this to study? Can we, you know, whatever? I said, you know, we've had since September, and the phone hasn't rung, and now we're here. And I 100% agree with Senator Bradley in that, you know, there was opportunity there, and nobody wanted to talk to us until then. And the last thing I want to point out is we've heard a lot of things about safety. Oh my goodness, this is going to be so unsafe. This is going to cause a lot of problem. The state of New Hampshire, I'm going to underscore again this, we have a regulatory board that's 100% about patient safety. It protects the public. Not only are they not here opposing this, but they say they're neutral on this. And the statement I'm going to send, I forgot to send it out to you, says they recognize the need for some of the changes that this bill does. So I appreciate it. Thank you for letting me finalize that. I'm going to leave this with you. And again, I hope you vote to pass this.
Well, I'm sure we're not going to trash it.
Yeah. Oh, that hurts. Thank you.
Yeah, absolutely. Senator.
Thank you, and thank you, Representative, for coming up and providing some clarifying endpoints. Just, there was a question I believe Senator Avard asked. I'm interested in what the licensure numbers are, say, 5 years ago till now, and can we go by zip code on where people are either practicing? 'Cause I know their home license, where their home address doesn't reflect where they work, but I'd like to be able to do.
I don't have that. Maybe OPLC would have that. I know they're really doing a great job changing licensing and really streamlining a lot of that. They may have that, and I can ask them about that. Be happy to do that.
That would be great.
All right.
Okay,
Thank you.
Thank you. And for that, your testimony and follow up, and we're going to close the hearing. And as soon as Cam's ready, we're going to listen to our next bill. Yeah, it's right here. Yep. Thank you. I kind of like this. Just kidding. So we're going to open up the hearing to HB 1584 and hear from the prime sponsor. Welcome, prime sponsor.
You should explain your joke to her, just so she gets it. Because Representative Peternell is my constituent.
As far as, okay, with
Limiting the amount of time of testimony.
oh,
She's
yeah.
in the hall waiting patiently.
Oh, after
She gets it.
We got two people.
I actually took it upon myself to request switching the order because I knew what I was going to be waiting through.
Oh, I'm sorry. I was just
That's
kidding.
all right.
I got to limit my humor. But anyway, you have the floor.
Sarcasm doesn't always play well here. Yes. That's okay. I understand. So, good morning and thank you, Mr. Chair and members of the committee. For the record, I'm Katie Peternell, representing Carroll District 6, the towns of Wolfboro and Tuftonboro. I'm here to present House Bill 1584, which is a simple, non-taxpayer funded solution to ease the current childcare availability crisis. This bill simply changes the number of children who can be cared for in a non-licensed home daycare from 3 to 4 children. The RSA amended by this bill is in the exemption section of the child care licensing statute. And this change could be of particular benefit to rural locations such as my own town, where there is a 1-year plus waiting list at our local child care center. And home daycare can offer benefits not found with a licensed provider, interaction, for example, interaction with multi-age children, flexible schedules, care given by friends or family. And it is possible to possibly less expensive since there are no regulations to contend with. The child to provider ratio is not affected by this change, and it allows the daycare provider to determine the ages of the children he or she is willing to care for, as well as setting their own limit up to the number of 4. I'm also going to email to the committee a letter from the state fire marshal, Sean Toomey, that this does not change the classification of occupancy in the state fire codes. So I ask you to please consider passing House Bill 1584, and I'm happy to answer any questions.
Thank you for your testimony. Questions from the committee? Well done. I see Representative Cordelli's here in support, but doesn't say whether he wants to speak or not. He's waving. All right. And then we have Melissa, who's neutral, doesn't, she's with the Department of Health and Human Services and is here if we need her. Do we need you? We're good.
The fire marshal's letter, you have that?
Do we have the fire marshal's letter? Oh, she's
Oh,
gonna
you'll email it? Okay,
she's gonna
thank
email
you.
it. Seeing nobody else wants to talk on this. Oh, Senator Bradley.
So I'm just reading the minority report. What? Yeah. I mean, seemed like that's about it. Not understandable exactly why Representative Berry was opposing the bill.
Representative Berry opposed it?
Yep.
I thought it passed. I'm sorry. I thought it passed on party lines.
I don't have that.
I don't know. Seems to make all the sense in the world to me. I'm sorry.
I'm sorry.
I got it wrong. He was actually supporting the bill. There was a motion of inexpedient to legislate, but then that failed and then ought to pass went through.
Right.
Got it. Okay.
You good?
I'm good.
Okay.
That explains it.
All right. Thank you.
And seeing no further discussion, unless you want to ask another question.
No. If Senator Birdsall were here, I'd say let's exec the bill today, but
She told me not to, and I do what I'm told. And she's listening right now. I can see the hairy eyeball.
I think you'll get an ought to pass motion from me next week.
Yeah. All right. And seeing with that, we're going to close the hearing, and I think we're done for the day. All right. I've been told, ARQ.